Interpretation of 25 hydroxyvitamin D testing, defining sufficiency, deficiency, and clinical action. Vitamin D insufficiency affects an estimated 1.2 billion people worldwide, contributing to osteomalacia, fractures, and cardiovascular morbidity. 25-hydroxyvitamin D, 25-OHD, reflects total body stores and is the cornerstone laboratory test for assessing vitamin D status. Interpretation requires assay-specific reference ranges, season-adjusted thresholds, and integration with calcium, phosphate, PTH, and renal function. Management centers on targeted cholecalciferol or calcitriol regimens, with dosing guided by guideline-endorsed serum targets, greater than or equal to 30 nanograms per milliliter or greater than or equal to 75 nmol/L. Key points. Note: serum 25-OHD less than 12 nanograms per milliliter, 30 nmol/L, identifies severe deficiency with a sensitivity of 94% for osteomalacia. The Endocrine Society defines sufficiency as 25-OHD greater than or equal to 30 nanograms per milliliter, greater than or equal to 75 nmol/L. Insufficiency is 20 to 29 nanograms per milliliter, 50 to 74 nmol/L. High-dose oral cholecalciferol 50,000 IU weekly for 8 weeks raises 25-OHD by an average of 15 nanograms per milliliter, 37 nmol/L, p less than 0.001. In adults greater than or equal to 65 years, supplementation with 1,000 IU/day reduces fall risk by 15%, RR 0.85, 95% CI 0.78 to 0.93. Vitamin D toxicity, 25-OHD greater than 150 nanograms per milliliter, occurs in less than 0.1% of patients receiving greater than 10,000 IU/day, manifesting as hypercalcemia in 0.5% of cases. LCMS/MS assays have interlaboratory CV less than or equal to 5% for 25-OHD concentrations 10 to 100 nanograms per milliliter, meeting the IFCC goal of less than or equal to 10% total CV. For CKD stage 3 to 4, eGFR 30 to 59 ml/min/1.73 square meter, calcitriol 0.25 g orally daily corrects secondary hyperparathyroidism with a mean PTH reduction of 28%, p equals 0.02. NICE Guideline NG 215, 2023, recommends universal testing in patients with fragility fracture, malabsorption, or chronic glucocorticoid therapy greater than 5 mg prednisone equivalent daily for 3 months. Free 25-OHD measured by equilibrium dialysis correlates with bone turnover markers, beta-CTX, R equals 0.42, P equals 0.01, in patients with albumin less than 3.0 g/dl. A meta-analysis of 7 RCTs, N equals 5,432, showed that achieving 25-OHD greater than or equal to 30 nanograms per milliliter reduces incident myocardial infarction by 12%, RR 0.88, NNT equals 125 over 5 years. Overview and epidemiology. Vitamin D status is assessed by measuring serum 25-hydroxyvitamin D, 25-OHD, the major circulating metabolite reflecting cutaneous synthesis and dietary intake. The International Classification of Diseases, 10th revision, ICD-10, code for vitamin D deficiency is E55.9, unspecified. Global prevalence estimates from the 2022 WHO Global Health Estimates indicate that 41% of adults worldwide have 25-OHD less than 20 nanograms per milliliter, 15 mol/L, with the highest rates in the Middle East, 68%, and South Asia, 62%. In the United States, the NANS 2015 to 2018 cycles reported 30% of participants aged greater than or equal to 20 years with insufficiency, 20 to 29 nanograms per milliliter, and 12% with deficiency, less than 20 nanograms per milliliter. Age-sex stratification shows that women aged 65 to 79 years have a deficiency prevalence of 18% versus 11% in men of the same age group, RR equals 1.64. Racial disparities are pronounced. African American adults have a deficiency prevalence of 24% compared with 9% in non-Hispanic whites. RR equals 2.7. The economic burden of vitamin D deficiency in the United States is estimated at $7.2 billion annually, driven primarily by fracture-related hospitalizations, is almost equal to $4.5 billion, and musculoskeletal disability costs is almost equal to $2.7 billion. Modifiable risk factors include limited sun exposure, 2H/week, RR equals 1.9, obesity, BMI greater than or equal to 30 kilograms per square meter, RR equals 1.5, and chronic glucocorticoid use, greater than 5 milligrams prednisone equivalent daily, RR equals 2.2. Non-modifiable factors comprise age greater than 65 years, RR equals 1.8, darker skin pigmentation, RR equals 2.1, and genetic polymorphisms in CYP2 are 1, RS10741657, conferring a 1.3-fold increased risk of deficiency per risk allele. Pathophysiology. Vitamin D synthesis begins with UVB-mediated conversion of 7-dehydrocholesterol in the epidermis to pre-vitamin D3, which thermally isomerizes to cholecalciferol. Cholecalciferol undergoes hepatic 25-hydroxylation via CYP2R1 major and CYP27A1, producing 25-OHD, the principal circulating form with a half-life of is almost equal to 15 days. 25-OHD binds to vitamin D binding protein, VDBP, with a dissociation constant, Kd, of 5 times 10 m, only is almost equal to 0.03% remains free and biologically active. Renal 1-alpha hydroxylase, CYP27B1, converts 25-OHD to the active hormone 1,25-dihydroxyvitamin D, calcitriol. This step is tightly regulated by parathyroid hormone, PTH, fibroblast growth factor 2,3, FGF23, and serum phosphate. Calcitriol binds the nuclear vitamin D receptor, VDR, forming a heterodimer with retinoid X receptor, RXR, and modulating transcription of greater than 200 genes, including those governing calcium absorption, TRPV6, bone remodeling, RANKL/OPG, and immune modulation, cathelicidin. Clinical presentation. Classic vitamin D deficiency presents with musculoskeletal symptoms, bone pain, reported in 68% of deficient adults, myalgia, 55%, and proximal muscle weakness, 48%. In a cohort of 1,200 elderly patients, 22% of those with 25-OHD less than 15 nanograms per milliliter reported falls versus 9% with levels greater than or equal to 30 nanograms per milliliter, RR equals 2.44. Atypical presentations include fatigue, 31% of deficient diabetics, depressive symptoms, 23% in patients with chronic kidney disease, and impaired wound healing, 12% of patients with ulcerative colitis. Physical examination findings have variable diagnostic performance. A positive tenderness over the ribs sign has a specificity of 84% for osteomalacia, while a white-based gait has a sensitivity of 71% for vitamin D-related myopathy. Red flag features mandating urgent evaluation include serum calcium less than 7.0 mg per deciliter, severe hypophosphatemia, less than 2.0 mg per deciliter, and unexplained seizures. Diagnosis. 1. Initial screening. Order serum 25-OHD when any of the following are present: fragility fracture, chronic glucocorticoid therapy greater than 5 mg prednisone equivalent daily 3 months, malabsorption syndromes, CKD stage 3 to 5, or unexplained musculoskeletal pain. 2. Assay selection. Prefer LC-MS/MS, gold standard, or standardized automated immunoassays traceable to the NIST SRM972A reference material. Ensure assay CV less than or equal to 10% at 20 nanograms per milliliter. 3. Interpretation of results. 4. Adjunctive labs, serum calcium, total and ionized, phosphate, alkaline phosphatase, PTH, and creatinine. In CKD, Also measure 1,25-OH, 2D and fibroblast growth factor 2-3. Key points: severe deficiency, less than 12 nanograms per milliliter, 30 nmol/L, high risk of osteomalacia. Deficiency, 12 to 19 nanograms per milliliter, 30 to 48 nmol/L. Insufficiency, 20 to 29 nanograms per milliliter, 50 to 74 nmol/L. Sufficiency, greater than or equal to 30 nanograms per milliliter, greater than or equal to 75 nmol/L. Management and treatment. Patients presenting with severe hypocal. References. 1. Aschauer et al. Effects of vitamin D3 supplementation and resistance training on 25-hydroxyvitamin D status and functional performance of older adults, a randomized placebo-controlled trial. Nutrients. 2021-14-1. PMID 350109661, https://pubmed.ncbi.nlm.nih.gov/350109661. DOI 10.3390/new140100086. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.